विश्व में हमने युवाओं की आईटी एनर्जी के माध्यम से अपना एक रुतबा खड़ा किया है और भारत इसके बाद के लिए गर्व कर सकता है। दुनिया में हम आंख में आंख मिला करके बात कर सकते हैं। और ये मेरा साथ मैं हमेशा कहता आया हूं, आईटी प्लस आईटी इज इक्वल टू आईटी। इंफॉर्मेशन टेक्नोलॉजी प्लस इंडियन टैलेंट इज इक्वल टू इंडिया टुमारो।
A very warm welcome and good morning to our day 2 of Hospital Infrastructure Summit today. And for the very first session of our panel discussion, the topic of our today's discussion is COVID 2.0 Transformation in Hospital Infra, the Way Forward. And I'm joined by our esteemed panelists today at our session, Mr. Gaurav Loria, who is the Group Chief Quality Officer and Head Operations Vice President of Apollo Hospitals, who is the moderator of the session today. We are joined with us by Dr. K. Madan Gopal. He is a Senior Consultant, Niti Aayog, Government of India. Dr. Venkat Ramana Sudagali, who is the Director and CEO of Excel Multi-Speciality Hospital. Gandharv Roy, COO, who is working at the Medica Super Speciality Hospital. Mr. Namit Soni, Director and CEO of Sony Hospitals, and Alok Agarwal, who is the CMO of Oriel Belt Limited. I move over to the virtual dais to you, Mr. Gaurav Loria, for gracing the occasion and moderating the session today. And I'll meet after the session once it's over.
Sure. Thank you so much, Pooja, and good morning, everyone, all the esteemed panelists here today, as well as the audience. Before getting into the introductions, a little bit more detailed introductions of all the panelists, I would just like to throw a little bit light on the topic that we are discussing today. COVID-19 pandemic definitely is going to serve as a milestone in the human history, with everything being divided into, we used to talk about before Christ, but it's going to be before COVID-19 BC, during COVID-19 DC, and probably after COVID-19, which would be AC. With actually the healthcare facilities at the background as the battleground, and India falling way short of the hospital beds that we have been seeing every day, there is no doubt that the healthcare facilities after COVID are going to be very different from before COVID. And as the virus spreads across the continents, I think it was clear that the new normal called for a new approach in the complete hospital design and architecture, or kind of modifying the existing concepts to a new requirement for creating isolation containment zones at a faster speed, and something that could be turned around as and when necessary or required in the future. We had quick fixes during this time, looking at exhibition malls, looking at shopping complexes, workspaces, hotels, to convert it into COVID care centers or the ICUs out of the necessity. but not as much as effective as they would have been if they were, developed for that particular purpose. And however, these makeshift isolation rooms definitely put the healthcare staff and the support staff who work in these areas at a significant risk. And, we have been seeing that being in the healthcare industry a lot. And I'm sure most of my colleagues on the panel would also agree with that. COVID has definitely made the world aware of the threat of the large-scale infectious diseases and the crippling effect that it can have on our lives. Therefore, if we have to live with the virus, which is going to be a reality in the coming years as well, or also be ready for the similar threats, we have to think of the long-term measures, have a better design in places we live and work. Healthcare facilities need to adopt the new way of design templates for the future designs, which need to be both culture as well as climate sensitive and the requirement sensitive. A shift from a single block design to probably a hybrid prototype, which can offer more of the outdoor interactions as well. And the focus should be on improving the sustainability of these buildings, which traditionally have almost high energy consumptions. Natural ventilation, no doubt on that. Integration of technology with digital infrastructure, as well as using a lot of virtual EICUs or the telemedicines that could minimize the contact and provide care on the same grounds as well. So with this basic background of the today's topic for discussion, that is COVID 2.0 transformation in hospital infra, the way forward, I would like to take the privilege of introducing our speakers on the panel today. May I start with the most experienced individual on the panel today, Dr. K. Madan Gopal, Senior Consultant, Niti Aayog, Government of India. Dr. Gopal is a healthcare professional with MBBS MD qualification and has been working on issues related to health system reforms and strengthening in India for more than 28 years. Sir is working with Niti Aayog, the apex policy think tank for the government, as a senior consultant for health. My next panelist is Dr. Venkat Ramana, Director and CEO, Excel Multi-Speciality Hospital, UK qualified senior consultant, radiologist, founder, director of Excel Hospitals. He's also the ambassador of UK Royal College of Radiologists and Oncologists and an advisor for global health tech and AI startups. He's also a quality improvement and clinical governance advisor, entrepreneur, globetrotter, with an expertise in clinical business development, team management, leadership, strategic planning, and he continuously strives to use technology to provide the highest quality of care across the globe. My next panelist is Mr. Gandharv Roy. He's the COO of Medica Super Speciality Hospital, mechanical engineer and administrator with his education from Michigan and INSEAD. He has been working at Medica for the last 7 years and has been very instrumental in driving mergers and acquisitions, leading to rapid expansion of the group. His core expertise has been strategy towards market expansion, exploration to newer markets, and driving technology to make operations easier and leaner. He's also a columnist himself, and he's well published in medical healthcare magazines and journals. The next speaker on the panel is Mr. Namit Soni, Director and CEO, Soni Hospitals. Namit graduated from St. Stephen's College. He started his professional career in 2010 by joining Soni Group of Hospitals, the family business of healthcare and medical education. Over the last 10 years, his leadership at organization as the Director and CEO has resulted in a significant growth, and he's taken the hospital from 2 in number at that point of time to 17 units today, serving more than 29,000 patients. He's been a pioneer and forerunner in bringing a quality-centered approach in healthcare of Rajasthan. Under his able guidance, the group also became the first and only NABH accredited group of Rajasthan in 2013, an initiative which was again spearheaded by Namit. Namit has at a young age helped the Soni Group of Hospitals grow from a small hospital chain to a major brand in healthcare as a provider, educator, philanthropist in the state of Rajasthan. Last but not the least, I would like to introduce Mr. Alok Agarwal, CMO, Orient Bell Limited. Mr. Alok heads marketing and product innovation at Orient Bell Tiles. In the last few years, they have filed patents for antiviral tiles, anti-static tiles, and launched many such special purpose tiles that are germ-free, scratch-free, cool tiles with specific focus on the needs of healthcare projects. Alok is quintessential IIT IM alumni, as comfortable with technology as with marketing, and as a chief marketing officer, his focus areas have been to accelerate transformation in the approach to building brands using digital and traditional media. In 2017, driving this change got him also recognized as the Digital Marketer of the Year. He has more than 15 years of experience in CPG marketing. He's built brand differentiation and also had 7 years of multicultural experience leading innovation for countries in Asia Pacific, key markets being Malaysia, Thailand, Indonesia, Philippines, China, and Australia. So, these were some very short descriptions of the great work done by each of the panelists who are on the panel today. And I would like to welcome all of you to the panel today. And thank you for joining today. So for today's discussion and for the benefit of the audience, we will look at primarily 3 rounds of questions. The first one, ideally focusing on the existing systems of where we are. The second one, probably focusing on the design thinking and what can we do better for the future to align with the requirements that are existing and that may come up again in the future as far as facility and infrastructure is concerned. I would obviously like to start with the most experienced person on our panel, Dr. K. Madan Gopal. And sir, would like to understand from you, based on your experience, the vast experience actually, can you tell us about the best practices for transforming India's hospital infrastructure that you think would fit into today's system or are existing? So you need to unmute yourself.
It is a very difficult question to answer. Frankly speaking, is very, very difficult. It's not that. If you have seen that despite having an infrastructure status since 2017, how many of the hospitals or the big chains they have utilized that opportunity? We don't know. We have PPP projects, but PPP projects, we have to really think that how it has evolved over the years. Apart from that, if you look at the bed distribution, is more or less 50-50% the government side and the private side. So what quality is there, we don't know. I'm just bluntly putting some of the facts. We do have a clinical establishment tax which sets some standards. That means the institution should be having some standards, minimum standards. But still, after 10 years, it's almost 10 years now, 2011 is 2021 now. We have to see that where we stand. These are the questions where we have to introspect. What is going on? And the big corporate hospitals and the chain hospitals, they cater to less than 10% of the population. They are more located in the bigger cities and some of the tier 2 cities. You have a not-for-profit model which caters to hardly less than 1% of the population. And if you look at the way the system has evolved, in the private sector also there are million providers, and for 1 lakh patients there are million providers. They have to chase with million providers to get a treatment. You see how the fragmented system is there. There needs to be. It has evolved. We have to see that why this fragmentation has happened in the private sector, as well as there is some fragmentation in the government sector. Everything has evolved in a fragmented way, and all the models, you talk about any model, that model is available in the country. You look at everybody is having their own interest now with the COVID era, as you have mentioned that we are now looking at malls and other things. Side by side, if you look at the incidents and the accidents which are happening in the hospitals, it speaks volumes about the infrastructure planning. At the cost of safety, we should not be, even the NABH accredited hospital, they are getting fire. They are reporting fire incidents. Then where are the standards? Where we are adhering to the standards? in this market, what we are doing is at the cost of safety, we want to expand. If some more space is there, you will always see that in that space, how many beds can be accommodated. You have to just pause and rethink what is going wrong. Even in the small countries, Latin American countries, if you go and see the ICUs, in the ICUs, all the relatives, everybody is allowed, but a space is provided. Can we think of that kind of? You have to think. That's the next question which you are going to ask. Nevertheless, I want to say that we have a structure. Ayushman Bharat PMJ was launched for the 40% population. To cater to that population, for the best of the insurance scheme, the utilization is around 3%. We have not yet reached that utilization. And we are having around 20,000 hospitals who are empaneled with that. But still, if you look at the ask, if 3% utilization happens per year in the BMJ program, that is around 40 crore, it's around 40 crore people, 40% of the population. If that population, 3% of that are seeking hospital care, do we have the adequate infrastructure, adequate beds? Because it's more or less secondary care. Do we have the adequate beds? No, we require at least 3 big hospitals in each of the districts which can cater to all this population. That number of beds are required. Second thing which is challenging is the manpower. Are we adequately investing in the manpower? Do we have the adequate manpower? Most of the hospitals which I have seen in the private government sector, they can't encroach on the recruitment rules. In the private, you see what kind of medical officers we are having. That's the introspection which we have to do. If you go to the smaller towns, we all talk about the HR and other things, but how the things are being managed, I should not be speaking on that. That's one thing. That kind of fragmentation has happened. One of the state-of-art big corporate hospitals and other things, and the other level not-for-profit hospitals which have been managed by this, that is called catering to hardly 1% sector, and there are a lot of mom and pop shops, mom and son, whatever you name it, but these are mom and pop shops, we usually call that, and they are there. 10 beds, 20 beds, 30 beds, as and when required, they increase the beds. We are not looking at that. The makeshift arrangement and this has given us an opportunity to pause and think that how many beds are more required in a very, very pragmatic and a very practical way. It's not that I would be requiring a big hospitals. Everybody, I was very struck during this epidemic, getting admission, making the people to get a bed in the hospital, that was arranged. Now they say that they are not being taken care. So what kind of care we want to provide when we are expanding this thing? That's the very, very bottom line. If you are expanding at the cost of the space and other things, then the other thing. If you want to provide more services, then you should not be compromising on the safety aspects. Over to you.
Thank you, sir. I think that was very helpful as you know, the starting point. And I think 3 words that I definitely picked up from the points that you had raised was, 1, to do a clear-cut introspection, to pause and then to rethink where we are and what we need to do. And thank you so much for that. With that, I would like to move to the next panelist, Dr. Venkat Ramana. And Dr. Ramana, obviously during this whole period, you know, we as a community, we as a country, we as, you know, people, we realize that how fragile our healthcare system has been, you know, what we were thinking and where we were actually. So will you be able to share a few challenges that you have faced in your respective hospital, or you have seen from an infrastructure perspective?
Yeah, can you hear me?
Yes, please go ahead.
First of all, I would like to thank Elets Technomedia and the team for inviting me, and wonderful panel members that we all have. Very good mixture of wisdom that we can all see. And I completely agree with Mr. Madan Gopal's, Dr. Madan Gopal's statements and his thoughts. Very eloquently put, words of wisdom, I would say. So actually, it's a very difficult question to really judge the requirement the need, because India is a unique country, I would say. We have got a mixture of extreme poverty on one side and a mixture of extreme well-off people on the other side. We've got urban and rural separate entities, one end having the tertiary care, which is world class, the other end we can't even provide sterile instruments for procedures. So in that instance, and the other thing that we always have to remember is we are still a young country with a massive amount of population. Distribution is also a problem because a lot of urban population and a young population, so between 20 and 45 is what our country's demographics are. And no wonder all these factors, including many other factors which we cannot talk in the limited time, has put a tremendous strain, and that has been obvious in the COVID times. And in fact, I am surprised to see people surprised, because this situation was bound to happen in a country like ours, with our existing infrastructure, with the amount of population that we have, oxygen distribution capacity and all. This was really bound to happen. But at least, many people who didn't realize now realized what the country's infrastructure regarding healthcare system is, and hopefully they should be able to do something about it. Regarding your question, Mr. Gaurav, very good question and very thoughtful to discuss this aspect. Infrastructure wise, the challenges, we all know, we have been in the news, we have seen everything happening and everything. But I would say the most basic challenge is one, of course, the distribution and the availability of beds and the infrastructure, which Dr. Madan has nicely mentioned. But I think at a very grassroots level, the policymakers should really do have a team of investigators, team of on the ground people to go to areas where there is a need, and have a statistics regarding every requirement. Not only infrastructure, but hospital infrastructure is not just about the buildings and the equipment, but also, as Dr. Madan said rightly, manpower. So where do we have the doctors? Where do we have the nurses? We should start training the doctors in the sense that, okay, can some people go to the remote areas? If not, can they do remote consultations? And remote consultations, for example, should be part of training as a medical student now, in my view, because that has become a common thing. So these kind of, I'm just giving an example, but these kind of basic retrospective view, we all have to go through and study what exactly is happening with the COVID situation causing an impact on the healthcare system, and what things that we can do in the future to prevent or at least lessen the impact that we all are facing at the moment. Thank you.
Thank you so much. And I think one of the points that I picked up from your, points that you had raised and discussed just now is that, India is a young population with a lot of potential. I think it's very important for us to utilize it to the optimal level, and that could help us largely to solve a lot of problems that we are facing or we are looking at it today. With this, I would like to move next to Gandharv. Gandharv, can you help us understand, with reference to the work done, especially by your hospital, as far as patient needs were concerned, and how you met their needs during this, time period of the pandemic?
So, Gaurav, thank you for having me here, and big thanks to Elets Technomedia for inviting me to this panel. With regard to what we did around COVID, now we sort of broke things up into sort of three elements, right? One is, rather four, if I really think about it. One is the patients who we are actually managing, who we're treating. We have patient relatives whose expectations you're managing by and large. You have the infrastructure, and then finally you have the people who are delivering care on the ground. So infrastructure, is one for anybody who's handled a change management initiative. Infrastructure is the easiest thing to do, right? If you want to do teleconsultations, you buy a bunch of computers and let's get going. But so I'll start with the easiest part, which is infrastructure. For infrastructure, we added about 175 beds. We took over a stadium. We added 175 beds with liquid oxygen supplies, ICU level, no sorry, HDU level care. So up to 10 liters oxygen. So we added some capacity there. We recently taken over the Calcutta Police Hospital in central Calcutta, where we're adding another 200 beds. Similarly, we've also expanded capacity within our own building. So we added another 75 beds. Now, these are all compressed air, ICU patients, ICU beds with oxygen. Basically, we have the works there. During this time, we made massive infrastructure changes as well, because we currently are the nation's largest ECMO unit. So I think Asia, as per the last check, we have about, as per yesterday's count, we had about 32 running ECMOs. So that's a fair amount of work that really goes into handling that kind of thing. And obviously there are some more, I'd say, mundane things like changing HVAC systems, right? Going from no pressure differentials to negative pressure, charting out the entire organization to see what the pressure differentials are at each point, and or figuring out how air is going to flow, air changes, all of that. And then more mundane things like, let's say, hand washing and sodium hypochlorite tunnels for when our patients, and so for when staff enters, to sort of maintains a sense of cleanliness. But that's just one part of it. I think one of the big things that we did was we really, really, really invested in our people. So we galvanized, we spoke to them on a regular basis. Senior members of not just senior clinicians, but senior administrators did regular rounds in the, put out their PPE, did regular rounds in COVID areas. What I did was that we invested in so much, for lack of better word, love and goodwill. We covered health insurance costs for nurses and families. We, if anybody got sick, we handled that. We obviously got all of them vaccinated. So we just invested so much. My head of neurosurgery is doing COVID rounds. I think the hospital administrators here can really appreciate how much work that takes from moving a mindset, because in the first wave, obviously that didn't happen because our critical care team was significant enough. But now I think we truly have all hands on deck, and it's an amazing thing to see people just coming down to the basic understanding of, look, I'm at the core of the matter. I'm a doctor and I'm here to serve. So give me the COVID protocols. I'll go and I'll do my thing. So everybody's helping out where they can. With regard to patients, I think the way we've structured our hospital is there's a lot of natural light. So we have fewer instances of ICU psychosis than at least our clinicians have seen in past hospitals. So, but for patients, the most we can really do is really just do our jobs. Secure oxygen supplies, secure medicine supplies, try to get the community as what do you call it? As prepped as possible. And finally, for patient relatives, really whose expectations are you're managing on a day-to-day basis, we try to initiate contact with the patient as much as possible. So, for example, I think every day between 3 and 6 p.m. a call goes with the patient's updates. Right? So we do our rounds in the morning, and in the afternoon, evening, or a bulletin goes to each patient relative. They get a call from the doctor, from the team of treating doctors, saying that this is what's happening, this is what's up, this is what's down, this is what our assumed prognosis is. We allow all of them to put on PPE and see their loved ones. So a lot of hospitals prevent patient relatives from coming in, but we've said that, look, if you're willing to take the protective measures required, by all means, go in, see them, be satisfied, because they're the ones who are suffering at times. Patients may be suffering physically, but these people are suffering emotionally and mentally. So we want to put them at ease as much as possible. And besides that, I think just conversing with them, you know what they need. And so those are by and large the big things we've put in place to handle all stakeholders.
Thanks, Gandharv, for that. And I think one of the important dimension that you raised in your talk just now was around investment in people. And I think, training, cross competencies, health insurance, changing mindsets. I think these are important dimensions that we should also look at, that may help, in the future, other than just the infrastructure. Moving on to my next panelist, Namit. So Namit, when I was going through your website, I read that one of the values of your organization is to have a well-equipped infrastructure. So if you could, tell us few points on how did you transform your infrastructure for COVID 2.0? Namit, you need to unmute yourself. We can't hear you.
Good morning, everyone. Thank you, Elets team, for giving me this opportunity. Gaurav sir, for the lovely moderating you're doing. And of course, all the esteemed panelists, I thank you for giving me this opportunity. Basically, sir, when we saw, and I just want to go from a macro perspective, then get down to Sony. So if you overall feel I have a slightly different perspective looking at how we've handled COVID, we have handled COVID, I feel, in India very well compared to how the globe has taken it. Everybody in the world has been run over in their infrastructure, whether it has been US or Italy or any other developed nation also. So getting run over and falling short of hospital's bed, everybody expected. But if you look at how we handled our first wave and how we handled our second wave and how we've been through our second wave, we two things that have come out very strongly. One is that there's a stark divide between our urban and our rural infrastructure, and I'll share that later. I'll just share that why I'm mentioning that. The biggest factor has been that when we were hit with COVID, we all started gearing ourselves, and as Gandhar mentioned, that we got our complete panelists on board, our team of doctors, our staff, all on board on how best we could pool in our resources and manage our patients, because all of a sudden we have hospitals like us who were focused on non-COVID like diseases, like lifestyle diseases and all of a sudden were thrown into infectious diseases, which were not our core forte. So to get onto that and get the whole team to start on that, that was our biggest challenge, and getting infrastructure ready for that. So for example, getting the BiPAPs, the high flow nasal cannulas, the ventilators, because you are geared for other facilities, you are geared for surgical expertise, you're geared for like say modular OT. So we have 4 OTs in our setup, and we were focused on cardiac procedures to get all of that and shift that towards COVID. So to convert, the government just overnight came up with the order, okay, 50% of your beds are reserved for COVID. But are we ready? Is our setup ready for handling 50% say medical management patients? No, we were not. That was where the challenge was. And I think the biggest thing we did was to break down the problem and to get to the basics of how the treatment is to be given. So we first divided ourselves into critical and semi-critical beds, and we divided our facility in half. Literally in half is how we divided the entrances, the exits, everything. We divided our infrastructure and we divided our equipments also accordingly, so that there is no overlap. The biggest challenge, and I think this is where Rajasthan did well, was that they gave us a queue at the start when they converted our premier institute completely into COVID and refused other hospitals to take up COVID. That gave us the hint that yes, if you merge COVID and non-COVID, the spread can be higher. There can be more problems, but when you completely make it black and white, there are no gray areas, then you have a better chance of fighting this disease. And I think that is where we as private centers in Rajasthan succeeded, where we divided our facility clearly into COVID and non-COVID areas. And I think most of the centers started doing that. But we did that in June and we were successful. In December, January, when the wave went light, we merged ourselves. We reduced our facility to back to non-COVID to handle those. And then again, we shifted gears in April. And the best part about infrastructure that my other panelists mentioned was infrastructure can happen in hours at times to change. But the biggest point of change is the manpower. And that is my second point I want to share. The point I mentioned earlier was urban and rural. So we have a center in a small town like Bagru. We have a 100-bed center there. And that center is catering to a town which has only 1 lakh population. So to have that center cater to 50 kilometer of periphery of Jaipur, a small out of our capital of our state, we faced the challenge there that the urban infrastructure was there still to cope up, but there is no infrastructure at the rural end. It was a complete collapse of systems because there were basically no blood tests available, no doctors available, no staffing, and all of that was unorganized. So if you ask me today, the biggest eye opener has been the way our rural and our healthcare infrastructure for 70% of our population is, because 30% of the population is well managed or at least has access to healthcare, organized healthcare, but most of our population doesn't. And that's where government, as Dr. Gopal said, that we need to really think on how and take a rain check on how we are looking at our healthcare facility, and definitely government needs to play a role in that. But what we understood from that was that the biggest uh, important is perception management, because when we started managing COVID patients, non-COVID patients, general public at large, I still remember that when we started COVID in our peripheral center, one of our doctors came COVID positive. It was full half-page front news on the newspaper there, which was surprising, because for us, if you're treating, there are people who will turn COVID, but the fact that it was half-page news and was that really impacts the public at large. So our biggest challenge and the biggest factor that we've looked at in infrastructure has been to get the complete infrastructure from equipments and manpower both ready in all our centers.
Thanks, Namit, for that. And I think one of the important points that even I have been telling everyone is previously we used to cater to patients. Now we cater to two types of patients. Non-COVID and COVID patients. So hence separating everything, duplicating the processes, duplicating the people, everything is I think really very important. With that, I would like to move to Mr. Alok. If and I would request him to throw some light on actually how the construction could play an important role while in the design phases. Probably if we would have done this before a little bit more sensibly and in a better way, this could have helped us to some extent in the existing environment as well.
Sure. Thanks, Gaurav. I really would first like to say thank you for your service. I think all of you have done a fabulous job and are still doing it. So thank you to all the doctors and people associated with the hospital for the service. People like us who supply building materials for construction are not really as close to the problem as you are. And, really hats off to that and completely admire you for that. I think Dr. Madan touched upon a very interesting point, which is that why is it a surprise? Or how should infrastructure be? And the sheer kind of stress the surge caused. And quite honestly, that's true, because pandemics, be it bird flu, SARS, now COVID, have been happening. So how do you really design a system that's literally proof of any pandemic? I mean, for example, maybe the next virus is not airborne, but it's fomite. It could be a dangerous bacteria. I mean, God knows what. I think so. We are thinking more on those lines and thinking what could we do to de-stress the system. So, for example, we recently patented antiviral tiles, which are effective against mRNA viruses in general. So, which makes sure that if there is a virus which is mRNA, 99% of it gets deactivated in less than 2 hours. Now, these are very simple solutions, because I often believe that we are designing in the hospital for 3 people. We are designing for humans, basically, and humans will have their follies. Be it the absence of nurse or doctors in rural areas, or even in the best corporate hospitals, the moment you are dependent on humans, saaf safai mein compromise hogi. So you need things that will automatically take care of things, which is why the antiviral tiles. Or let's take, for example, you will move wheelchairs and stretchers in hospitals. They will be stacked against walls, be stacked against uh, all kinds of surfaces. So how do you make surfaces scratch resistant? Because the moment you have a scratch, it's a breeding ground for everything. Right. And that's how we came up with forever tiles, which were scratch free, which made sure that not even a knife or a screwdriver can scratch it. You basically require a diamond to scratch it, and that is hopefully not so commonly found in the hospital infrastructure area. Uh, we all hear horror stories about uh, fire happening because in an oxygen rich environment and that kind of a situation. Quite a lot of this has happened because uh, vinyl was used indiscriminately, and understandable. There are lots of great things about a vinyl. It's absolutely free of joints. It's got great acoustic properties. It muffles it. So I understand uh, the greatness of vinyl, if I may call it that. But I think we need to balance it out with the potential fire hazard or the potential maintenance, or how do you manage it in a tier 2, tier 3 town? Because a vinyl would need to be replaced even in the best corporate hospitals in the next 2 to 3 years. Now, are we really going to see that kind of replacement frequency in the tier 2, tier 3 hospitals? Or are people just going to live with cracks on the vinyl or cuts on the vinyl? Again, a breeding ground for all kinds of stuff. So, we developed anti-static tiles, which can really ground electricity. You can potentially use it even in an operation theater. You can combine it with grouts, which prevent growth of microbes. So the whole system not only grounds electricity, but is also not a breeding ground for microbes. Uh, I think one of the biggest challenges uh, hospitals face is managing spare capacity. On one hand, I'm really thrilled to hear the way uh, people have been able to add hundreds of beds of capacity. But one of the pressures that's very real in a hospital is how do you ensure occupancy? How do you ensure that the capacity utilization is really high? In that way, it's similar to a hotel. And if I may say so, the electricity cost is about 600 rupees a bed, or anything between 40 to 50% of your normal electricity cost. Now, how do we help you manage that electricity costs? I think some of the things that you could do is perhaps start investing in cool tiles, which actually reflect the heat load and keep the indoor temperature, thereby sustainably lowering the kind of electricity running expenses you need to do. Now, again, these are system solutions. And you really can't do this once the hospital is done. And this will be increasingly useful everywhere. So, I mean, you can go to the best corporate hospital in Delhi, Bombay, wherever, but bathrooms in public areas would get cleaned only at a certain frequency, maybe 4 times a day, maybe 6 times a day. But then what happens in between cleans? Now, there are germ-free, antibacterial, antifungal, mold and mildew tiles that are available, which can keep the environment safe. You can have anti-skid floors, you can have suitable colors, and there is a whole science to colors as well, and which is a very different kind of a session as well. So, for example, if you're making a patient bathroom, you can do with soft pastel shades. On the other hand, if it's a bathroom or a, let's say, uh, a lounge for the hospitals and for the staff and the doctors, you might want a brighter, vibrant colors, because unko tab pastel shades nahi dekhna. They want to actually recharge, refresh, and they need something that's much more alive and vibrant. And they are humans. They are humans like all of us, and they want a break from that patient environment, and they want to feel fresh, alive, and get back to work. Because I can completely understand and empathize that the work is okay, horrible, and it's dealing with a lot of pain. So might as well refresh them. So I think there are lots of steps that you can do on the design, both for a corporate hospital or for a PHC, to make it sustainable and literally, if I may say, automatic cleaning, automatically reducing the kind of heat load it has. So that's it from my side.
Thank you so much for actually, helping us understand a lot of important points around facility and the infrastructure part of it. With this, I would like to move to the next round, wherein I think we should also focus on the design principles, the design thinking, and how should we actually approach the problem. I would like to come back to Dr. Gopal, and sir, if you could help us understand in your observations what should be the approach actually going forward to reimagine the hospital design to respond effectively to emergencies such as any of these kind of epidemics or pandemics in the future. Sir, you need to unmute yourself, please.
Very pertinent question in this current scenario. There are very quite few trends, as Mr. Alok has pointed out. A very useful thing that needs to be considered, because the way the origin of this black fungus, we don't know from where it has originated. It is there in the environment, but had the person got it from the hospital, had he got it from elsewhere, we don't know. We have to know from where the person has got that infection. So these trials and the environment, they play a very important role. That's one of the factors which we need to factor. The second thing is we have to rethink the hospital design and the best practices in order to make the hospital safe and sustainable. The vinyl trials which he was mentioning, they had to be replaced 2 years. But as our habit, we, do we think of replacing that thing? We will say that चलता है चलने दो जितने दिन चल रहा है then उसका देखेंगे. We have to adopt standard protocols. We have lost many of our colleagues during this pandemic. Basic reason is we have to adhere to the protocol. Do we have the manpower to adhere to that protocols? Protocol is that the person in a pandemic COVID duty, he should not be doing more than 4 hours duty. If that basic principle is not followed, we have to have standard operating protocols for all the hospitals. If the person, whatever competence he may be, after he has clocked the time, we should request that now it's time for him to rest. We have to preserve that thing. We have to see that whether if a pilot is safe, let the plane crash. The whole of the effort, the resources which we have put in the pilot, he can fly the plane again. But we have to see that how we nurture our resources. It's not that putting pressure that you should be doing 6 hours job, 10 hours job, 12 hours job. Initially, 4 hours job was 4 hours. This pandemic duty was there. Then obviously shifted to, and now 12 to 16 hours they are doing. What they are doing there? If you are not able to have a SOP, we have to see that in the standards how the SOPs are built into this for the manpower as well. Whatever standards are there, they are from the point of view of the safety of the patients. Now we have to think about the safety of our staff, because they are the resources with which hospitals and other things work, and the healthcare business and other things also run because of them only. We have to see that how we protect them. You might have come across corporate policies where the heads of the institution, they don't travel in one car, they don't travel in one flight, they have a staggered flight plan. Everybody is not flying on a same plane. That kind of measures, that kind of SOPs are to be there so that the staff is protected. That's the first thing which I want to say. Second thing, when we are redesigning things, how to triage the patient before they enter the hospital. So that's the important thing. That's the important consideration which we have to make. Either it is OPD or the emergency, we have to see that multiple entries, multiple waiting rooms, how we can factor that thing in the given space and other things. Then we have to reimagine the waiting rooms and the building spaces, public spaces. We have to reimagine things so that the mixing of the patient, the crowding and other things can be factored in. You have to see that how the this appointment system has been factored into this. It's not that it is a free for all and they can walk in and get something. In the emergency, it can happen that the spacing and other requirement would be different. But for OPD consultation, essentially you have to see that how the crowds are managed at all the times. Then we have to see that how touchless technology to reduce the manual and touch-based interfaces are included in the routine practices. There are many things automatically opening doors, the touchless temperature checks, then touchless hand sanitizer we have already seen. The touch points are being replaced by voice recognition and activation. That kind of innovation will come in the coming days. during the post-COVID area. Then improving infection prevention in clinical and non-clinical area. That's an important area, as Mr. Alok has rightly pointed out. That's the area which is of concern because nobody looks at tiles and other things. They think एक बार टाइल लग गया 10 साल के लिए फुर्सत होगी. But there's a major source of microorganism and major source for hospital infection. That means we have to focus on infection control measures. It's not that the infection control measure means if I'm doing a procedure, only one shot of antibiotic. After that, no antibiotics are required. That should be the level of the sterilization, other things, which I have not seen in any of the hospitals in the country. Operation, high doses of antibiotics, whereas the practice in the Western world is very different. Only one shot of antibiotic during the surgery. After that, they will watch for fever and other thing. If infection is there, then the hospital will find out that why that infection has happened. We have to have build in that kind of SOPs in the coming years. Then we should be having infrastructure for telemedicine and virtual consultations. So that's very important because we can't be having all the people as the late Dr. Agarwal sir has in this last message saying that we should be having virtual consultation in groups. The group having a similar kind of thing, that kind of thing we have to start thinking on that. Then apart from that, we should have a surge capacity planning for the inpatient. In case of any catastrophe and other thing, what kind of surge we are able to manage. You might have seen the district hospitals whichever are near the highways and other things, they are not operating at the full optimal capacity, but they do have spare beds in case of any disaster or anything. Immediately from 50 beds operational bed, they raise it to 100 operational beds. That kind of planning is to be there. We don't know when the catastrophe will come. And we can't be blaming the hospital that they are not prepared. Then apart from that, we should be having isolation rooms. This time, most of the hospitals which were having a high-end ICUs, they were hard-pressed to treat the infectious disease because we never thought that we would be requiring infectious disease ICUs as well. Most of the ICUs, they are designed to take care of the cardiac patients and the other patients who are requiring high dependency care as well as the intensive therapy. But we have to see that how we can have isolation rooms for the infectious disease. Previously, in the hospitals when we used to study, we used to have infectious disease ward. Now that concept is more or less down over because now, one example I'm citing in Delhi, if somebody is having diarrhea, how many of the hospitals would be admitting that patient, including the corporate hospitals? Very difficult answer. Unless you are linked, because they don't have that kind of room to handle the infectious disease patient. We have to plan for the infectious disease patient. And lastly, the only thing is that we have to see that how we develop the HR, how we nurture our HR, how we have built in the SOPs so that we protect our HR, that the human resources which are the backbone of the hospitals of the institution. We have to see that how they are protected. In case of any pandemic, there is no emergency. You have to first protect yourself, then you serve. If you are not protected, then how you can serve? And we have seen not many people have died. No over enthusiasm. You have to stick to protocols. If you look at the pilot, if they have done 10 hours duty, they have to take mandatory rest. Mandatory quarantine was there during the first phase. In the second phase, all the guard has been gone. If the person has taken 2 shots of vaccination, to be doubly sure, you check the antibodies, whether the person has developed antibodies or not. Instead of just relying on that I have taken to this and I can work for 12 hours, 15 hours, 16 hours. This is all from my side. All the best. I have to leave for another meeting. Thank you very much for this. In case of any question, you can WhatsApp me or you can send me.
Sure, sir. Thank you.
Thank you very much. Sorry to all the panelists that I could not continue further on the discussion because one more meeting is lined up. So that is pertaining to COVID only, so I have to be there. Okay,
sure, sir.
Thank you very much. Thank you for this opportunity.
For all the points that you had raised, sir. And thank you for being there. I would like to move on to the next question, and this would be a common question for all the other panelists to respond. Understanding the current times when we may not have been prepared so well, how do you suggest we should go about in approaching the infrastructure piece or the design thinking piece in such situations? Would like to start with Dr. Ramna first, followed by Gandharv, Mr. Alok, and then Namit.
Thank you. So this question has been partly answered by many of the eminent panel members, but I'll tell you my own example. I'm a radiologist and I'm still active in my clinical practice. So approximately 50-60% of the time, I devote myself for direct patient care, because I think that is what gives you the ground level understanding of what is happening. So, if you see the example of radiology, it's actually a groundbreaking change that we all had. There is a system called PACS, which I think most of you know, where all the films, in fact, they were all silver-based films, which we were all developing in a dark room, just like pre-digital photography era. But now everything is digital, and they all have to just send it on computers. So that actually got very well established during the pandemic, and many of the radiologists, and I work for UK still, being in India. I work for UK, Ireland, Australia, and many countries, and we were still able to carry on our active practice. And many of the Indian hospitals also had locations remotely to continue their active practice, keeping the doctors safe, which was the top priority. And of course, in some situations where ICU doctors have to go in directly, it is impossible. But at least, we could do that thing, and we could keep the doctors safe and carry on, because as Dr. Madan quite correctly said, you have to protect yourself first. To save others, you have to save yourself first. And tragic that we have seen many doctors dying from the epidemic. Still, a lot of doctors and healthcare workers, including the nurses, cleaners, for example, are still waiting on the vaccination list. But see, we all have to remember that India is such a big country, and there is always a constraint in terms of infrastructure, in terms of manpower. Mobilizing all these together, especially in the pandemic, is very difficult. We have seen advanced countries also suffering. But what India suffered most uniquely and most tragically, in my view, was patients died not just because of COVID, but patients died because of lack of proper infrastructure. And it's very good that we are having this meeting, because it's an eye opener for all of us, that infrastructure, including deaths due to fire accidents, deaths due to lack of oxygen. So these are the examples that many people have died. It only makes sense that infrastructure has to be developed, rethought about at a grassroots level, and maybe we can contribute in the future in whatever way we can. Thank you.
Thank you, Dr. Ramna. Gandharv.
Thank you.
In with regard to preparing future pandemics or future exigencies, I think it will be insufficient, or nor do we have the amount of time that we would like to necessarily go into issue by issue matters. I think, for example, one of the things that we can do best is, and it sounds a bit morbid, but it's called memento mori, which is to remember death, right? Think about risk. Think about risk management. So, see, all these things happen in cycles, right? We had the Spanish flu about 103 years ago. This has happened. The signs of it happening. These things will come. These things will go. But the fact of the matter is that we have not spent enough time remembering death and thinking about all the things that could hurt us, and accordingly preparing a playbook for each of those things. I think that we have enough qualified, intelligent people, but they need direction from leadership. Leadership has to say that, look, we are going to sit and we're going to have a discussion around these are all the things that can cause us and our communities and our society immense damage. How are we going to create a playbook to deal with each of them? That's part one. And the second part, which stems from that, is also how we build resilience and how we balance resilience versus efficiency. I think that's a very, pointed discussion we need to have and think very deeply about, because hospitals, schools, and places of worship tend to be very integral parts of communities, and hospitals, as you know, are they are constructed as refuges, right? So we already know they're very integral part of the community, and but unfortunately, because we a lot of hospitals, and including the one I work at, is a for-profit entity. We also need to look at the bottom line. We look at the return on capital employed. So I think that having a longer discussion about how we build resilience into our P&Ls, frankly speaking, how we build resilience into our P&Ls and balance that with the responsibility um, that I wouldn't even say that we've taken, not just because we facilitate healthcare providers, but that's also where we have chosen to invest our time and effort into. We need to balance that, though these two very fundamental issues that are constantly in conflict with each other. So I think that's essentially where it comes down. Just
Thanks,
these.
Sundar. I think very important points that you spoke about. Mr. Alok, would you like to go next, please?
Sure, sure. I will try and be brief to help you with the time. One of the things I think we need to do better in designing hospitals is to try and build independence from humans. Humans are fallible. Humans make mistakes, be it doctors or nurses or the cleaning staff. So you need to design for independence from humans. Uh, we were preparing for COVID too, but we were not prepared for black fungus, and this will keep happening. I don't know what form and shape COVID-3 will be, but we have to design for a broad spectrum of viruses, bacteria, and fungus, so that whatever you build, like a temple, lasts for the next 50 years. And lastly, but not the least, designed to minimize system cost. It's not only the construction cost, but the operational cost as well, and look at the system cost as a whole and work towards minimizing it.
Thank you. Thanks for that, Namit.
Hi. So, in regards to design thinking, instead of focusing on infrastructure, I'd like to put on design thinking. The biggest thing that I feel we should learn from the pandemic is how to manage change within our manpower. One small change that we tried to inculcate and do throughout was to maintain touch with our complete team throughout the pandemic at the start with the first lockdown, and then continue that through regular. Kind of meetings, smaller meetings in person, larger meetings through these digital platforms to maintain a communication with all your manpower, whether it was your doctors, whether it was your nurses, or whether it was your staff at the fourth level, the ones that are taking care of patient on the ground, the helper staff. And those things really give you a lot of input into what they are facing on the ground with terms of these new diseases, new problems, the way your treatment is being given. So that we do at a macro level, but we should start doing it with different people in mind and groups in mind. Instead of looking at, say, usually at least at our level, we used to do a town hall, and then we used to do it departmental meetings. But that was not good enough, to be honest. What was required was to divide them into segments of their profile, and then take them together cross department to understand what were their challenges. So when we are looking at providing care, our biggest thing was to manage the change within our people. And like the COVID, like one strategy we felt was successful was that what was temporary has to be taken temporary, and what will be a permanent change has to be taken as a permanent change. So in our first wave, we took COVID as a temporary change, but after that, we took COVID as part of our DNA and system. Now that we will be dealing with infectious disease, or we will be dealing with COVID now, not just for 3 months, but for at least a year, whether it is our surgical patients, whether it is our walk-in patients, whether it is our OPD patients. So our systems need to be designed in such a way that we consider this as part of our working now. So we have to get used to the fact that in our OPD we will have patients walk in who would be unaware of this disease. We would be having patients of surgical background who would require this. So we have had a complete change on the clinical front. We need to have that same change in our processes, on ground, as well as our communication to our patients. One small change we did was we divided our zones into colors, hospital into zones with colors, where we differentiated a non-COVID zone, we displayed a COVID zone as a red zone. We differentiated an orange and a yellow zone where we mentioned high risk non-COVID zone and a low risk COVID non-COVID zone, so that people were aware. And we, with those colors, we defined what precautions need to be followed, so that they are the biggest thing we learn from the Western or the developed world is the kind of communication, clear communication with dual languages and pictorials they do. We should adopt that same, and I think that is where we lack here in our Indian subcontinent infrastructure, is the way we do our signages and our communication with our walk-in patients or with our patients, our attendants, relatives and all. And I think those kind of soft changes or quick fixes in my language can really make an impact on how we deliver care to our patients.
Thanks, Namit, for that. And I think one clear lesson that each one of us have learned from the pandemic is that our current infrastructure lacks the flexibility to accommodate a sudden surge of patients. And I think that is one area which we really need to look at in the future. And definitely preparedness is prevention for the future. Due to the paucity of time, I would just take one question which has come in as to what's the plan or view for a possible third wave. For me, I think, if we go by the researchers and the analysts, the data that they have been predicting, they have predicted a third wave. But I think what is going to help is basically two things. One is, as I said, preparedness is prevention. To understand where we are, we have seen the first and the second, we have seen what's happening around the world, what we need to do more to improve on our end. And I think the second important point is vaccination. The more and more people take vaccination, it's definitely going to help a lot to individuals, to the country, and to the community at large. Even we have seen in Apollo hospitals that all the staff that got infected were only 2.6% of the staff who had actually taken both the doses and they got infected, but none of them had any touchwood, any bad consequences. So I think vaccination definitely helps a lot going forward, and that should be our plan. Would any one of you like to add anything for this particular question?
One more thing I'd like to add regarding the third wave and how we could prepare for it is that definitely we are seeing that the younger population is being targeted. I mean, we saw in the first wave the population above 60 was vulnerable. In the second wave, we have clearly seen patients from 25 to 60 have really increased in numbers. So we really need to, and we should start prepping up our infrastructure for the younger patients, especially for patients below the age of 20, pediatric and neonatal patients, mostly pediatric, I would say. And we have already had a discussion with one of the key specialists in our town, 4-5 of them, how we want to prep up for that. So it's just a preparation, and preparedness is probably half the job done. So my thought here is that we can only prepare and plan for this, but we are hoping that if the vaccination picks up, we don't need to look at a third wave if we are able to vaccinate our population fast. So that's...
Yeah, and just adding on, yes, absolutely. Vaccination is the first and foremost. But besides that, I think there will be some aspects of government policy that'll be quite important. Because, I mean, I don't have kids, but I have nephews, and they're extremely non-compliant with their masks or any sort of social distancing. So I think depending on what kind of policies we put into place with regard to whether schools are open or not, and I understand that has a cost on society with terms to education, because not everybody has access to e-learning. But if I may be so bold as to say that it might make sense to actually accelerate vaccination for neonates and kids, even before getting into the sort of 18 to 30 level, primarily because it's easier for them to be compliant than the younger ones.
Yeah, I think I would just add that it's impossible to be prepared for the third wave, and and you can war game the scenarios, but there is a huge reservoir of viruses. There is innumerable number of bacteria and fungi. So look for a broad spectrum of defense against microbes. So if you are constructing something, be it a home, office, school, or hospital, please do your research and do the right thing.
So thank you so much, everyone. With this, I would like to, thank the IELTS team for inviting all of us here and, for having this topic and the discussion. I would like to thank all the panelists, who are there and who had to leave because of the other prior commitments. So thank you so much for being such a great panelist today. And also thank the audience who have been with us for the last almost an hour. Have a great day and thank you so much. Over to you, Pooja.
Thank you so much for the very insightful panel discussion for starting the day today. And we would like to present the speaker certificates to all of you. If we can please
Pooja,
have
can I just thank Gaurav ji?
Yes, please, sure.
Yeah,
Sure.
I mean, sir, this is one of the most organized panels I've been attended. I mean, hats off to you. Lovely.
Thank you so much. Thank you so much, Namit.
Thank you, Mr. Gaurav Loria, for moderating the session today.
Thanks a lot.
Thank you, Dr. K. Madan Gopal, for being with us. Dr. Venkat Ramana Sudagali, thank you so much, sir. Thank you, Mr. Gandharv Roy, for being with us today. Mr. Namit Soni, thank you so much for being with us. Alok Agarwal, sir, thank you so much for being with us today. Thank you so much, all our panelists. We are coming back again at 12:15 p.m. for another panel discussion. Thank you so much.
Thank you. Have a great day, all of you.
Bye.
Bye.
Bye bye. Thank you.